So, good morning, everybody. Welcome to the CPD program conducted by SRI, the Society for Health Research and Innovation. So, let me remind you of the housekeeping options, like their housekeeping rules. So, first is keep your mics always off so that the others won't get disturbed, and also your videos off. And this meeting will be recorded. So the webinar link will be available from 9 a.m. to 9:50 a.m. to join in, and all late attendees will be entertained thereafter. Each attendee should have been attended till the end of the webinar to obtain certificate for CPD points, and the CPD points are strictly adhered to the NC-CPD guidelines. So this is to improve and maintain the standards of CPD programs conducted by SRI. So thanking you for the strict adherence for the CPD regulations and your kind compliance. So asking questions, the question time is at the end of the webinar, and if you have a question, please type it in the chat box, and please change your chat settings to all panelists and attendees so your question can be answered. And if you have very specific questions about your topic, please email us on this email. So today our topic is pediatric triage. Do I need to worry about this child? So it's very important and timely topic. And our honorary lecturer today is Dr. Michael Jansz, the consultant pediatrician, preliminary care unit, Lady Ridgeway Hospital for Children, Colombo. So let's start the discussion, and over to you, sir.
Okay, thank you very much. So, good morning. I'm Dr. Michael Jansz, consultant pediatrician from Lady Ridgeway Hospital, PCU. So, my topic is pediatric triage. Do I need to worry about this child? So, at our unit at LH, we are the first to see the ill children. So, it's very important for us to detect who we need to see first. And it's very important so that we can start the correct management and resuscitate quickly, and so there is no delay. So this topic is very important to us, and during this lecture for about 45 minutes, it will be a short lecture. I'll be going through some of the basic things. These are just basic stuff that all of you will know, but we'll try to get it right in a sort of order so that it will be easy for us to detect any ill children. And I'm sure if you go in this order, it will be very useful for you and help you to detect ill children quickly in your practice. So in this lecture, we'll just talk about triage and its important, and why it is important to detect the ill child quickly, and the signs that will help us to detect an ill child, and especially the objective signs that we'll use in a triage in children. And methods available to suspect, detect early, and escalate treatment of a child with an acute illness. So a little bit about triage. So this is actually coming from a French word. So this is initially this has been started during wartime. So during war, when there are casualties, they've used this system to categorize the victims. So victims that cannot be saved with categorized in three categories initially. So victims that can be saved with medical care, those that can't be, and those that don't need any care. So initially this was used in the fields. Later on, actually quite recently, these triage systems have been used in hospitals. So basically what is happening is you're conducting a preliminary assessment of the patients and try to determine how urgent their need is. So the definition I took from a dictionary: conduct a preliminary assessment of patients in order to determine the urgency of the need for treatment and the nature of treatment required. So we assess very quickly and decide the order in which the patients will need treatment and the nature of the treatment. So like I said, in hospitals, it's quite recent, maybe in the 1960s when this triage started, and it's mainly in emergency department setups. And in our setups, of course, the OPD also level, it should be there. So when we categorize patients, then we have to decide how we categorize. So there are various ways of categorization. So this I've taken from the National A&E guidelines of Sri Lanka for emergency department. So they have categorized into three categories. So category 1 is a red patient who need immediate resuscitation. Category 2, emergency, that means fairly quick. Category 3, urgent, so not as quickly as emergency. Category 4, non-urgent, and they have added a fifth category, death patients. So this is the national guideline. So different countries and different units will have different categories. So this is for our national ANE guidelines. So this is a categorization that taken from Australian ANE. So here they have decided the category, then give a time requirement. So this is important thing, not still available in our setups. So category 1 needs for resuscitation, so immediate treatment. Category 2, emergency treatment within 10 minutes. Category 3 requires treatment within 30 minutes. Category 4 requires treatment within 1 hour. Category 5 requires treatment within 2 hours. So this is another system. The simplest system is three categories: red, yellow, green. A traffic light system. This is what the WHO has recommended. So category 1, red to be seen immediately, green urgently, and yellow urgently, and green non-urgent. So this is the system that we use in our hospital as well. So emergency cases, red, immediate emergency treatment. Priority cases will have a rapid assessment and action. Non-urgent cases can wait. So like you said, the emergency check for emergency signs, emergency treatment. So priority yellow patient check for priority signs. If there are rapid assessment and treatment. If no priority signs, non-urgent. So the difficulty comes in how we decide the category. So how do you decide this category 1, category 2, or category 3? So in different settings, how they decide this will change. So in children, it's particularly difficult to decide which category they have, how ill they are. This is because children are very difficult. So there are various reasons why it's difficult to categorize. To identify illness in children. So one of the main things, they obviously can't communicate their distress. So the smaller the child, more difficult this will be. So most of our information will come from the mother. So second-hand information. So sometimes mothers may be over anxious and exaggerate the symptoms and signs, or they may not be able to understand if the child is sick or not. So then it becomes very difficult to decide whether the child is ill or not. So other thing in children, when they deteriorate, the signs of deterioration may be very non-specific. So they may be getting worse, they may be getting bad, but it's very difficult to detect. And when deterioration occurs, it occurs rapidly. So there's a compensation for a short period of time, and suddenly they collapse. Suddenly they become bad. So it's very important to detect the subtle signs, whether they are ill or not. And other things, if you have an ill patient, yes, interventions are very difficult. So child is physically small, even to get close to them is difficult. So if you have a baby, first we need so many people to look after them, but physically it's very difficult to get close to them. And interventions are very difficult. So how difficult is it to get IV access, and when the child is crying and restless, it's not easy resuscitation. So it's very important to detect things early so that we don't have to face. So we won't have to face these difficult situations frequently. Other thing is children. If you detect the problem early and you treat early, you will generally have a very good outcome. So unlike adults, they have a huge potential alive. But even the smallest thing can lead them to a disastrous situation. If we detect quickly and treat, everything will be fine. But if you don't, if you miss, it could lead to a disaster. So we have to decide how we can identify ill child. So we can do that by history. So if there are things in red flags in history, that will get an idea whether child is ill or not. So very high fever, ill-looking child, less active, reduced feeding, reduced urine output, and any specific pathology. So if there's a history of poisoning, if there's a history of snake bite, or if there's a history of suggestion of dengue, so that will give you some idea from the history. So the mother's concerns are very important. So I said sometimes the mothers might exaggerate or might not give the whole picture, but if they are concerned, we should be always worried. So mother is concerned about the child, we should, if you, even if we, initial assessment, we think the child is okay, we should always take another look and say, most of the time the mother is correct. And I think it's personal experience. If you have a very experienced nursing officer or even attendant who tells you that the child is not okay, listen to them, because they have like a sixth sense. So these are ways of identifying an ill child in your setup. So these are generally, some of these are not objective, they're subjective. So to identify it, it will be beneficial if you have some objective signs and symptoms that we can assess a child, and this will help to triage them. So objectively, a good standard way of looking assessing is the ABCD approach. So airway, breathing, circulation, disability, and exposure. So looking at these parameters, we can get an idea whether the child is ill or not. Having said that, when we are assessing, we have to remember very important children that their normal rates change with age. So you have to know the normal rates. So especially respirate, pulse rate, most important, blood pressure, urine output. So as you see, according to the age, the normal rate is changing. So if you have a child more than 12 years, the respirates are close to adults. So more than 12 years, normal respirate is 15 to 20. Heart rate 60 to 100. But if you take a child less than 1 year, the normal respirate will be 30 to 40, pulse rate will be 110 to 160. So as you get bigger, the normal rates increase in respirate, pulse rate, and blood pressure. So you should be always have an idea what the normal rate. Otherwise, you won't be able to assess how ill the child is. So let us go through some signs and things that to see that we should assess, that we can use to assess whether the child is ill or not. So the first thing is, as I said, we go through the airway, breathing, circulation, disability, ABCD method. So first thing is to look at the airway. So obviously check if the child is breathing. So not breathing, it's a red patient. So immediately you have to take some action. So you might have to use airway maneuvers like head tilt, child lift, or jaw thrust, and open the airway and see if the child is breathing, and immediately start resuscitation. So this sort of patient is obviously red patient. So we won't be looking at parameters. Immediately we will take some action. So our next question is, if the child is breathing and child is talking, can vocalize, then we are not worried about the airway. So that gets excluded very quickly. So then there are other few things in the airway that we should look for. So is there an airway obstruction? So if there is a stridor, that means there's a partial upper airway obstruction. So in a stridor, you get a harsh inspiratory sound. So it's a suggestive of a partial upper airway obstruction. So this is a red sign in children. So a partially obstructed airway, it might lead to a completely obstructed airway. So you can get these airway obstructions in viral croup, foreign bodies, bacterial tracheitis, epiglottitis, and even in anaphylaxis if you have upper airway swelling. So this is stridor, immediately it's a red patient, don't disturb the child. Immediately you have to go in and start management. So there are other sounds in the airway that you should worry about. So if you have a child who is looks very drowsy and has a snoring sign, you have to worry whether the tongue has fallen back and whether there is an obstruction. So in that case, again, we have to do the airway maneuvers, head lift, chin lift, and open up the airway and start resuscitation. So snoring sound, reduced conscious level, red patient. So if you have secretions and there's like gurgling sound, that also means that the airway is compromised and there's a chance of aspiration. So you have to open the airway and you might have to suck out secretions. So these sort of patients, these airway problems, immediate red patients, immediately start. So this video I'd like just to show what stridor is. So in that video, you can see there is a harsh inspiratory sound and there are some recessions as well. So child does not look that ill, so most likely it is a viral group, but there is a partial airway obstruction. So you have to worry about this child, treat patient. So obviously in the airway things, you don't disturb the child much. You immediately take and start assessing, check the saturation, see whether it needs oxygen, and see what the cause for the stridor is and try and sort it out. So it's a viral group, you might need some steroids and nebulized adrenaline. So once airway, if the child is talking, speaking, can vocalize breathing, you're not worried about the airway, you go to the next thing, airway breathing. So breathing, most important thing is the respiratory rate. So I mentioned earlier the normal rates. So unless you know the normal rates for the age, we can't interpret the respiratory rate. So the respiratory rate, the more it is, if we know the normal rate, the more it's away from normal, the iller the child is. The rate is much higher than the normal rate, we know the child is very ill. It's less than the normal rate, it's even worse. Because if it's less than the normal rate and the child is ill looking, most likely he has had some respiratory pathology and is getting exhausted and the respirates are coming down. So this is coming close to arrest. So you have a patient with a high respiratory rate for the age and one that's low for the age and both are ill. The more dangerous one is the one with the low respiratory rate. So respirate is the most important thing in breathing. Next, you have to check the respiratory effort. So in the respiratory effort, you are seeing what the effort the child is taking to breathe. So you can look at intercostal, subcostal recessions, accessory muscle use, alar nasal flaring, and wheezing. So I'll just show you this video of a child with distress. Okay, so in that video, there's subcostal recession and child is breathing fast. So that it should be obvious that this child is in distress and needs immediate to be seen. So red patient. So you can see some accessory muscle used there. Alar nasal flaring, I don't have a video. That is in the, you see a child with breathing fast and fever, and then if you see the nasal flaring, that's a suggestive of pathology at alveolar level. So if you have a high fever, tachypneic child, alar nasal flaring, it's a pneumonia. You can get it also in severe bronchiolitis in small children. It's a bad sign. That means there is some pathology at alveolar level. So I talked about accessory muscle use, subcostal and intercostal use. So in adults, you use the sternocleidomastoid as well. So in a child, when they are using the sternocleidomastoid, you get what is called head bobbing. So that head bobbing is because this child is using the sternocleidomastoids as accessory muscles and the head is going up and down. So that's a bad sign. So if you see that, the child is not well. Again, red patient. It's important to see sounds. So if you say the child.
When a child is brought to you, let's look and listen again. When a child is brought.
So in that earlier video, we saw a child is breathing fast. There are subcostal intercostal recession and we can hear wheezing. So that's most likely acute severe asthma. So again, that patient is a red patient. And immediately we might have to check the saturation, and saturation will start some oxygen and start nebulizing salbutamol, implement and steroids. So if we don't detect that patient and he's in a queue for a long time, he might become when we see, if we delay seeing him, when we see him, he might be desaturation and become worse. So it's important to detect that. So there are other signs that we look for in the respiratory system to see if the child is ill. So grunting. So grunting is it's a very if your child is grunting, it's a very bad sign. it means that what's actually happened is that there might be segmental collapse of the lungs, and there might be smaller airways might have collapsed. So what the child is trying to do is, by nature, the child is trying to make this sound and increase the pressure in the airways and open out the lungs. So you get this grunting sound. So I'll play this video. If you detect this, it's a bad sign.
There we go.
So grunting is a bad sign. So always look at this chest expansion, yeah, entry and saturation. So those sinus. If there's sinus low saturation, obviously red patient. There are various abdominal breathing patterns that which should be red flags. So the child is getting apneic, especially this happens in the neonates or in infants who are less than 6 months who have various problems, maybe bronchiolitis. You'll see that they are getting apneic. So that's a bad sign. So abdominal breathing is another sign. If you want to see what abdominal breathing is, I'll show you a video. But if you want to see it on yourself, you just feel your tummy and breathe in and see what happens to your tummy. You see that it goes in. So in abdominal breathing, what happens is when you breathe in, the tummy is going up. That is a sign of respiratory failure. It's a very bad sign. So I'll show you a video of that. That's a sign of respiratory child. While the child is breathing in, the abdomen is going the other way. So seesaw breathing. It is imminent about imminent respiratory failure. So you have to immediately take some action. Most likely, child will go into respiratory failure soon. So we talked about some things in airway and breathing that we look for. So A, B, C. So in C, in the circulation, we are seeing 7 things actually. So the pulse rate. Again, we can't interpret the pulse rate unless we know the normal range for the age. So, and the higher away from the normal it is, the more ill the patient is. So pulse rate, pulse volume, capillary filling time, blood pressure, whole lines. Whole line is you feel if the child's extremities are cold. So if they are cold, you check, go proximal. So if you're checking on the foot, you go to the leg, thigh, abdomen, see where the cold line is extended to. So if it's extending up to the abdomen, that means child is in severe shock. But if it's just the feet, there might be not much of a problem. So cold line is can give you an idea how badly the circulation is affected. Urine output is a very good sign of intravascular status. So always we have to ask if the urine output is reduced. And we look at the color to make sure the child is not pale and not any blood loss. So these are things, and other things, the capillary fill time. It's actually a very useful tool that we don't use enough. So get used to checking the capillary fill in children. There are some research articles that show that it is identifying the level of intravascular volume better than certain investigations. So this is a very simple thing, but important that you do it properly.
And 1, and 2, and 3, and 4, and 5, and 1, and 2, and 3.
The capillary fill time less than 2 seconds is normal. So we went to A, B, C, D. So in D, we are just basically seeing the CNS. So the CNS, we are checking a few things: conscious level, posture, and pupil. So conscious level, very quick way to check is what is called the AVPU score. So AVPU score is alert, the response to voice, response to pain, or unresponsive. So any pediatric patient less than alert, you should be worried about and see why the conscious level is low. So if responding only to pain, it's a very bad sign. That means the GCS is less than 8 and your airway is at risk. So in that sort of it, the patient is responding to pain, you have to immediately see whether open the airway and see the cause for the low conscious level and treat immediately. So ABP very easy. You just write ABP and see circle what the child has. So if it's alert, there's no problem. Anything less than that, we should be worried. So if you have any reduction in conscious level, you can check the GCS. So there are special GCS for children, not like what you get in adults for the head injury. It's depending on the age. So you have a scope that's there for less than 4 years, and another one for above 4 years. And so in this scope, basic like in the adult scope, we have the 3 parameters: eye opening, best motor response, best verbal response. So it's modified. So example, best verbal response in less than 4 years, you see, babbling, cooing, less than usual words, tries only to pain. There are some differences. So we can always assess the conscious level formally with this, and it's important in the GCS not one measurement to see the whether it's getting better or not. So if you have a patient, what is commonly present to us, children with febrile convulsions. So after we treat, the GCS will be low after a fit, but it's important that we keep on reassessing. So soon after the fit, if the GCS is level, we have to reassess and see whether it's getting better. If it's getting better, we are not worried. It's part of the natural process. But if it continues to be low or it's getting worse, then we have to look for other pathologies. Yeah, so we looked at in the D, we looked at conscious level. The thing is posture. So there are certain postures that if the patient presents with this, these are very bad signs. So can you see on the left is what is a decorticate posture? So I'll list like that. And decerebrate is the other way. So it's easy to remember decorticate, caught the ball. So you see rugby players when they go running and catch the ball, they catch it like this, caught the ball. So decorticate, the other one is decerebrate. So these are very bad signs. If you have a patient like this with this sign, that means it's a sign of raised ICP. Some pathology is going on in the brain. You need to immediately resuscitate and see what's going on and manage. So pupils, the thing is we check in the pupils in the CNS. So you can have constricted pupils, dilated pupils. So constricted unilaterally, constricted bilaterally, dilated bilaterally, or it can be dilated or constricted unilaterally. So the constricted ones, there are not many conditions, pontine lesions and poisoning with opiates. Dilated pupils bilateral, this is more common. So again, poisoning with atropine, ischemic brain injury, and if there's a severe herniation. If you have a unilateral dilated pupil, it could be a herniation on one side or a midbrain lesion on one side. That's a good thing to remember. Children who are fitting, sometimes you get children who are fitting who are in focal fits, and you can't see the generalized tonic convulsion. So they have dilated pupils. If you have focal fit, you might have a unilateral dilated pupil. We have A, B, C, D, E. So exposure also important. Temperature. So a child with high fever is it's more likely to be having a problem. So rashes. There are various rashes that if you see are very important to detect if a child is ill or not. So you have a febrile child ill and is having a non-blanching purpuric rash on the lower limbs. Might be a meningococcus sepsis. If you detect that quickly, you might be able to save the patient. But if you delay, these patients, they deteriorate very quickly, go into septic shock very quickly. So sometimes children with staph infections, they might have a rash or strep infection. So rashes are very important. Also, if there's an obvious trauma, so if you have a non-accidental injury, you might have some features of trauma in the patient. So important to detect. So we went through a lot of signs that are there in airway, breathing, circulation, disability, and exposure to detect the ill child. So those signs, where we were working, it's important. They are very simple things, but A, B, C, D. If you look at those signs, you'll be able to not only detect ill child, some of the diagnosis and you will be get. So if you have VC, you know what the diagnosis is generally. But in a triage, what we are looking at is patients coming to the OPD or emergency department, and we can't look at all of these signs together. It still takes time. So we need a quick way of assessing. And initially, it won't be a medical officer, a doctor. It will most likely be a nursing officer. So ideally, it should be a very experienced nursing officer. We'll have a very quick look at the a patient, ask a few questions, and maybe use some of the observations that we were discussing to decide whether the child is ill or not. So, doing this, there are various tools that can be used to identify ill children. So, this is one such tool. This is a tool used to identify the category 1 red patient. So we are looking at 3 things. Some of the things that I showed in the ABC are here. So you are looking at just the general appearance and the major presenting complaint, the work of breathing and the circulation. So so the child is sleeping, wake them up and observe head to toe. So you see the general appearance and the major presenting complaints. So if there's reduced alertness or not responding, fitting, fever with lethargy, acute change in gait, limb weakness, acute dysphagia, severe unbearable pain, unstable with major trauma, poisoning or inundation, immediately becomes a red patient. In the breathing, if the child is apneic, if there's stridor or gasping, or hyperventilation or extreme respiratory distress, cyanosis, again, category 1 red patient. So circulation, if the child is pale, cold, poor pulse or blood loss, again, a category 1 red patient, immediate resuscitation. So actually speaking, the red patients, immediate resuscitation patients are most of the time they are pretty obvious. If you have an experienced nursing officer, we can immediately recognize and take into the resus room to start management. So the next category patient, so just another way of things. In our unit, we have a similar method for detecting the red patient. So again, we are going A, B, C, D. So like in that other slide, A, arrest, apneic or stridor. B, hyperventilation, gasping, extreme respiratory distress. C, pale, cold, poor pulse, blood loss, dehydration. D, any reduction in conscious level below alert. Acute changes in gait, dysphagia, dizziness, limb weakness. And we have taken inhalation and fitting fever with the blood. So any of these things there, the few questions and the nursing officer looks at the general condition, feels the pulse and with the cold or not, looks at the respiratory rate, and if any of these there, immediate resuscitation. So the red patient, like I said, it's fairly easily recognized by the nursing officers. Even the mother will probably recognize and come running with the child in, so go straight into resuscitation. But the next category, the yellow category of patients, sometimes it will be difficult to assess. So these children might not be. So we need to work out a set of things that we look for in these patients. So in our unit, we have made some list of things that we are looking for yellow patients. So any child with reduced activity, any history of foreign body, any allergic reaction, any breathing difficulty or effort breathing, any vomiting, diarrhea, or difficulty in swallowing, in decreased urine output or decreased oral intake, or any history of dengue, very high fever, limb pain, any difficulty in walking, any history of fits, or if they have had low platelets in any investigations done, any neonate, any child on immunosuppressive with drugs, on immunosuppressive drugs with fever, or basically the most important thing, any child that looks unwell. So these patients we have to reassess. So they don't need immediate resuscitation, but they will need to reassess their parameters and see how quickly they need to be seen. So then our questions are, how do we reassess these patients, the yellow patients? So there are various objective ways we can do this. So one of them is we can use what is called a pediatric early warning score. So there are charts and charts tables which, if you mark on this, you can get a idea, a score. So I'll give you an example of this. Give you an example of a Q's table where we can objectively see whether the child is ill or not. So this is a pediatric early warning score. It's a table actually. So it always has to be age related. So example, if you see this is age is 4 to 11 years. So you have to have it age related because the respiration, heart rate, and blood pressure, the normal range will change for the age. So this one says 5 to 11 years. And if you look at the left, we are taking a few parameters. These are basically the parameters that we were talking about earlier. So we can't choose all. We have chosen a few parameters. So if you look carefully, we have chosen the respirate, respiratory effort, saturation, heart rate, systolic blood pressure, capillary fill time, and AVP. So depending on the where you work, the amount of what the parameters that you will use and the amount you will use will change. So this we have in our unit, we have used the minimum amount of things. We are just taking in 7 things. And so when we look at the respiratory rate, if the respiratory rate is normal, if we look in the middle, the score will be 0. The respiratory goes high, the score will keep on going high. So in the respiratory here, 16 to 29, score is 0. It's 30 to 39, 1. 40 to 49, 2. So higher the rate is, the score is more. Same way, the lower than normal, it goes down 1, 2, 3. And you see, if it's respiratory is very low, you get a high score. If it's high, very high, you also get a high score. Same with the respiratory effort. No distress 0, but if you get mild distress 1, higher than that 2, 3. Again, saturation is normal 0. If it's lower than that, you get a higher score. So heart rate and blood pressure and capillary filling, same as that, as well as the AVQ. If the score is child is alert is 0, if there's anything less than 0, we are giving 3. So what happens when the nursing officer, the yellow patients, there are some complaint they are not sure, we will try and reassess them with the pediatric early warning score. So we'll look at the respiratory and mark it on this chart. The respiratory effort will mark, saturation, blood pressure, exercise, and we'll mark and we'll add up a score. So when you add this score up, generally if the score is less than 2, the child is not that ill, we can see slowly. But anything more than 2, we have to see the child quickly. So we promote that patient to a red patient if the score is more than 2. So we can use this to again sort out the yellow patients and see who is to be seen quicker. Because what the parameters that we're looking for initially might not be enough to detect the ill patient. We might need the score. So this is a pediatric early warning score, the table, and you can get some numbers. So the different countries will have different pediatric warning scores. They might have more parameters than this, and so we can't compare the numbers from our score from what is usually different unit. So this is only for units. Some there will be scores with more parameters than this. So, like you see, the triage in red case, like we detected earlier, immediate treatment. The priority goes as rapid assessment action. So. So before that, so we check the priority signs. So if the priority signs, we take in the pediatric score and needs rapid assessment and treatment, the score is high, we treat immediately. If the score is low, we can wait and see the more serious patients first. So while we're checking the score, actually, we might not even check all the score. If we see that the saturation is low, immediately we will take the child in for resuscitation and immediately promote to a red patient. If the ARV, so this is the category 3, the ARV patient. So if you look at the ARV, if the ARV patient is vocalizing, crying and feeding, ARV is okay. If you look at the breathing, there's no respiratory distress, no normal respiratory rate, no increased work of breathing, and the pulse rate is normal, child is warm, rate is normal, and child is alert. And there's nothing in the history says these are green patients, so they don't need to be seen urgently. These ones are quite obvious. So in our setup, we'll send them straight to the OPD. You see in these charts, so you might ask why we don't check it for all the patients. So thing is, if you go to check this for all the patients, it's very time consuming. So if we go to check it on the red patients, we'll be wasting time and these patients will have delay in treatment. So if they find this for the red patients, it's easier to immediately assess them and start treatment. The green ones also actually can be seen quite quickly with the ABC. These yellow patients are the ones that neither in red or green, those ones we might have to do this pediatric early warning score and then decide whether they promote them to red or promote them to green. So like I said, we can use charts or tables. So we showed a table there. There's another thing, there's a chart that we can use as well. We'll just show you the table. It'll show you a fuse chart. A fuse chart, it's a color chart. So it's a color chart like this. So we're checking some parameters. And like in the other one, it's age dependent. Like I said, the normal range will change with age. So this chart is for a under 3 child under 3 months. So there'll be charts for under 3 months, 3 to 1 year, 1 year to 4 years, 4 years to 12 years, and 12 above 12 years. So this chart, we are looking at some parameters. So the first one, if you can see, is the airway and breathing. And the airway and breathing, the respirate is there, respiratory distress and saturation. So the respirates are very high for the age, and if you mark it on, it will come to the red. If it's not less than that, it will yellow, green, and white. So normal it will be white. Very ill child will fall into the red. Very ill child, that's the urgent child will fall into yellow. The green one will be slightly bad, but will not need immediate treatment. So the respirate, respiratory distress, saturation, and again we'll have circulation as well in this chart. So in that, there's the pulse rate is there, capillary filling time, and the blood pressure. Again, if you mark it for the age, it will decide the chart. It's from the chart itself, you'll be able to see whether the child is a red patient, yellow patient, or green patient. So in the other side of this chart, there's a need to look at the AVPU as well. So in these charts, we can see the respirate, work of breathing, saturation, pulse rate, capillary filling time, blood pressure, and the conscious level, AVPU, and decide. So if any of the parameters in the red, is a red patient. Enlarge this chart. So again, age dependent, and we have the respirate, respiratory distress, saturation, and how much oxygen the patient is on. And on the other side, next part, we have the circulation, heart rate, capillary filling time, systolic blood pressure, and disability AVPU. And this has a pain score as well as the temperature. So anything coming the red, automatically you know the child is ill. So the importance of this chart is you can monitor frequently. So if a patient comes with asthma and you look at the respirates and the heart rates and the saturations, and they are mark it on the age dependent charts in the red. So you give oxygen, you give steroids, back-to-back nebulization, and you see with time the respirates are coming down, the heart rates are coming down, the saturation is getting better, the oxygen requirement is getting better. So you know the child is getting better. So it's a very good way of monitoring the child. It is getting worse, better or worse. The same way, if you are, let's say you have a patient with bronchiolitis, you are giving oxygen, but this child continues in the red, then you know that child is not getting better. Then you know you have to step up. So it's very important. This is not only for rejecting patient. You can use this chart for monitoring and deciding which patient we need to step up. So even though we triage patients, sometimes they might be yellow, but they might turn into a red patient while we are seeing them. So very important to see this. Okay, so that's about it. We have some time. So about questions.
So thank you so much, sir. And dear participants, you can post your questions in the chat box so that sir can see and answer.
Yeah, there's a question about BCG scar. So yeah, those are in a pediatric ward setup, yes, BCG scar, but not for emergencies. So this is not important.
Sir, and we have some questions sent from the previous registration form. So they ask, how do we assess the consciousness?
Yeah. So the conscious level in emergency, easiest way is what we call the AVPU score. So A is alert, V is respond to voice, P is respond to pain, U is unresponsive. So just write AVPU. See if the child is alert, just circle A, there's no problem. If the child is responding only to voice, there's something wrong. So that in pediatrics, anything less than alert, be careful. Then next one is P, responding only to pain. If you respond to only pain, that means your GCS is less than it, you're in trouble. So it's a very easy way of assessing the conscious level. If you have a child with reduced conscious level, then you can look at the pediatric GCS chart. So you don't have to worry about remembering the chart. You just download it and check the best eye response, best verbal response, best motor response, and mark it.
Thank you, sir. And another question is early signs to identify that child need an expert opinion. What are the early signs to identify that child needs an expert opinion?
Yeah. So I talked about this the red signs. So anything that we got in the red, it's definitely needs resuscitation. So again, go with the airway breathing circulation. So if you have any child is not breathing, obviously start your basic life support. If there's if they're having secretions, again immediately. If there's stridor, so a lot of the patients might come to with the stridor. So stridor needs expert opinion. Breathing also, it's important to see the rates. If the child is breathing very fast or below the normal, or having a huge workout breathing, or if your setup, if the saturation is low, again assess expert opinion. Circulation also, anything, any severe tachycardia or poor pulse volume, or in your history, if you have a child with a snake bite, obviously, or a toxin, or if you're having dengue and child is ill looking, expert opinion. And anything on conscious level, of course, any child who is reduced conscious level, yes.
Thank you, sir. And next one is when a doctor advises parents to admit their child to hospital, if they refuse without acceptable humanitarian cause, what can we do as a consultant, MO, OPD, MO, pediatric, or a GP?
Yeah, you can get the question again.
So when a doctor advises parents to admit their child to hospital, if they refuse, like what can we do?
At the OPD level,
Yes, sir.
yeah, at the OPD level, I think it's a very difficult problem because actually speaking, they can't refuse because it's a different life now. So there's yeah, so they should. What you can tell them, don't let them send them alarm from the OPD. Tell them to go to the ward and go alarm from there. Don't send
Oh.
them. Because legally we can run into trouble because it's a different life now. If an adult refuses to admit, they are taking the responsibility. This is a different life. So only thing with the legal setup, we can't get it done in that time. So better to admit and let them go alarm from the ward if they're going. So there somebody will speak to them and consultant will speak to them and explain again. No? So better not to take the chance from the OPD level.
And they ask, so how does pediatric triage differ from adult triage?
Yeah, the basic principles are the same. No, they are looking at the only thing is the children, like I said before, they are more likely to deteriorate very quickly. So if you take the red patients here, in the adult one, most likely we will take only the immediate resuscitation. No? Here in the red patients, we are taking some people with the potential to deteriorate. So example, if you have a child who has ingested a toxin or a snake bite or even asthma who is breathing slightly fast, we'll promote them to the red one quickly because the potential to get worse is more. So we'll have more patients in the red yellow than the adults because the adult will have a bigger capacity and will be hang on longer.
Yes, thank you, sir. And how can we decide whether we need to do a CT or not when a child comes with trauma?
Yeah, trauma part, of course, I'm not expert in. So actually speaking, that should be from the surgical side. But there are in other countries they use various scores for which unit they work in. So they'll have a guideline. So if these have these features, you have to do it. So in our setup, of course, we are not the ones who see that. We refer to the surgeon. So I don't think they have an exact score. So I don't think you can give an expert opinion on that.
Thanks. So another question is, should we as doctors be an anxious mother for a child with normal vitals?
Can you say that again?
So should we as doctors should be concerned about an anxious mother, although the child's vitals are normal?
Definitely. Even if they are normal, the mothers, even though the mother may be over anxious, but we see is that mothers they have a sixth sense. We can never ignore that. If they're anxious, just keep the child and have a look at.
Sir, another question is how to differentiate periodic breathing and tachypnea in a newborn in an emergency.
Yeah, the periodic breathing, what you can do is you can count for about 1 minute and see. You will see that the rates are normal then. The other thing is you can look at the other parameters well. So with this increased work of breathing, so in the period there won't be increased work of breathing. You can look at the saturation. You can look at the general conditions. So all those will be normal, and the mother also will not complain on any poor feeding. So everything else will be on. It will be only the periodic breathing, and the things you can count it and recount it. It should be okay.
Thank you, sir. So another question in the chat box is, are there different criteria to detect deterioration in consciousness in a differently able children like CP patients?
I'm actually not so sure that I don't know of anything like that. I don't know that neurologists might have one, but as far as I know, no, there might be, but I'm not. I don't know.
Thanks. So another question is, can a baby develop sepsis with infected BCG scar?
Yeah, the thing is, the sepsis. It's possible. It will depend on the read, but it's again there'll be a process, isn't it? So the infected BCG, it will take some time. So it's possible, but it won't be emergency. You'll have to look at the other parameters. So if you have the infected scar and the child is well, probably you can see them slowly. So that is mean that you send them away, but you don't have to immediately resuscitate. They can. So I can't say no.
Thank you, sir. So another question is, can we send any child with any severity lama from the ward if the parents are requesting?
Yeah, that is also a problem because it's the legal part is there. No? So in our setup, they are going, but when they go, they are going to another hospital. So what I do is, if they're going to another bigger hospital, government hospital is bigger than if I work in a small hospital, I ask them why they want to go, and if they are not happy with the manager, I will transfer them the hospital rather than them going Lama. Uh, Especially if there's some problem with them. If they're going to a private hospital, of course, I can't stop them, but we have to get the things. But to prevent them, we can't. The legal thing is, even though we can have a legal problem, it's impossible to prevent them.
Yes. So another child is, even though, sir, please explain how to identify and manage common acute poisoning scenarios in children by ingestion.
Yeah, that's totally. It's a different topic itself. So it'll take about an hour for that as well. So what was the question? Poisoning, no?
Yes, sir.
Yeah,
Acute poisoning scenarios.
Yeah, that will take another hour to explain.
Yes, sir. We will arrange another.
Arrange one
like,
from another
session, yes.
poisoning expert.
Thank you, sir. So another question is, when do we take the decision to intubate a child?
Yeah, that intubation, that's a difficult thing. It will depend on the pathology, So can't take it as a one blank thing. So it will depend the so don't worry about intubating immediately. The take-home message is first. If you're having a patient, first look at the airway, open the airway, give oxygen, see the work of breathing, see the pathology. So it's depending on the pathology different. So if, for example, if you have a child with a fit and you're given midazolam and stop breathing, you won't intubate. You'll open the airway, give oxygen, maybe some bag and masking, it will settle at its own. So, but if you have a child who is having a pneumonia and his respirations are down and got exhausted and carbon dioxide is retained and there's acidosis and he's going to go to respiratory rest, then of course he will electively intubate. So you'll get the best person there, anesthetist or intensivist, and give proper drugs and intubate. So it will depend on the cause. It's difficult to say a blanket. That also probably a different lecture, total different. It's another 1 hour lecture probably by anesthetist or intensivist.
Yes. Thank you, sir. And they ask, is it okay to give 0.9% normal saline to any child who is hemodynamically unstable on admission, even if the child has hyponatremic dehydration, which we might not know at admission?
Yeah, it's okay. You go for normal saline, 0.9% saline, it's fine. don't worry about that. That other things, if you have hyponatric dehydrated, you are unlikely to go into shock. But even if you have, give the normal saline. Fine,
Okay.
0.9 saline.
Yes. Thank you so much, sir. And they asked to arrange APLS programs for doctors in peripheral hospitals. So we can do something about that also in the future. So
Yeah, I think we are having the APLS at LRH every twice a month, and already in Kandy and Karapiti they are starting it. So I think the regional centers might do it as well as to go out and do. I think we go out from the regional centers and go to small hospitals and do shorter PLS courses. So I think that will happen more frequently in the future.
yes. Then thank you so much, sir. So we will be concluding the session today.
Thank you very much for having me.
And our speaker today was Dr. Michael Jansz, consultant pediatrician, primary care unit, Ridgeway Hospital for Children. So, and another few reminders that I need to give it to you, that you can fill the feedback form at our chat box, and also fill the post survey so that we can issue you the e-certificate and request for the e-certificate. So thank you so much for everyone for participating, and we will end up for today. So good day.